Okay, why don't we get started? So good afternoon again, and welcome to today's town hall that's being co-hosted by the Perinatal Neonatal Quality Improvement Network of Massachusetts and the Betsy Lehman Center for Patient Safety. I'm Barbara Fain. I'm the Executive Director of the Betsy Lehman Center, and we are happy once again to be partnering with Penguin on the 6th, hard to believe, an online forum for exchanging up-to-date information about COVID-19 and pregnancy care. So next slide, I just want to mention a few housekeeping items. If you are having technical issues, you can just send a chat to Alex Zhang and she will help you out. You can also send chat questions for the presenters for the later Q&A as we go along, and just feel free to note if your question is aimed at a particular presenter. And then finally, I always want to mention that we do record these meetings and the chats as well. So if you have any concerns about that, you can feel free to send a chat to the Betsy Lehman Center. Next slide. So this is not, it's not a disclaimer. It's really just an explanation that the information that that is presented during these town halls is, it's constantly evolving. So, so some of the information may change. Some of it may not be universally applicable, and you should be sort of thinking about how to adapt it to your own needs. And really just, everyone, there's just this constant need to stay up to date on the most recent guidelines and protocols. Next slide. We also want to recognize that that many of you, really everyone, has a need not only for information but for emotional support during these just very, very challenging, unusual times. And so we wanted to make sure that you were aware of resources that are available to you. Go to the next slide. So the Betsy Lehman Center has curated a set of support resources, and it's on our website, and we update these frequently. And you don't have to write these down. We will be sending you these slides later on, so you're going to have access to all of the links. Without further ado, let me now pass the baton over to Ron Iverson, who, along with Audra Meadows, co-chairs the Massachusetts Perinatal Quality Collaborative.
Great. Thank you very much, Barbara. And thank you to the Betsy Lehman Center for all the great work you're doing on this project with us on the virtual town halls. First, thank you very much to the three speakers who are here today. I'm excited to hear what you say. And I also want to thank everyone who's joining in today to listen and to chat and to participate. I have 4 slides on data because we are data driven. This is the first slide just to show folks where COVID is showing up through our state. You can see where large populations are. Of course, there's more COVID. Next slide, please. Thank you very much to the Mass Perinatal team, which is nurse leaders throughout the state who meet and talk about issues in perinatal health. You can see their meeting schedule there. Mimi Pomerleau and Bonnie Glass and others are involved if you'd be interested in connecting with them. Last week on the 8th, they asked where the COVID deliveries were occurring. So this is an informal poll. I know that some people probably weren't on the call to report, but thank you for those who did, just to give you an idea of where our deliveries are occurring, largely in the Latina and African American populations, and that's what you're seeing here. Next, please. We can see that we continue to increase our testing throughout the state. Our testing positive rate, which is the lower graph, actually is decreasing, and it's not clear whether that's because of less disease load in the state or changing criteria for testing, but you can see there that we continue vigorous testing throughout the state. Next slide, please. Thank you. And this is really a plea to make sure we include race and ethnicity on all of the information that we return on patients to the state and other sources, because it really is hard to know exactly how to focus our work and how to appropriately implement and roll out work within our hospitals, within the state, within regions, without knowing which populations to be working with. So without further conversation on this, I want to move on to Dr. Nicole Smith, who is from the Brigham Women's Hospital and who's going to give us some pearls on ambulatory care. So thank you very much, Dr. Smith. Take it away.
Thanks, Ron, for the introduction, and good afternoon, everyone. So I'm going to be talking about some of the challenges that we're facing with postpartum care. I think we're all probably familiar with the transformation of both antenatal and postnatal care to be partly telehealth and partly in person. And, I think in our group, we're worried quite a bit about what's going to happen during the postpartum time, given that it's such a high-risk period for mood disorders. When women have interrupted postnatal care, we have concerns about substance use disorder, about hypertension management, screening them for type 2 diabetes, getting contraception, decreasing their utilization of LARC. For background, of course, we have fewer and fewer women that really want to come to the hospital for their in-person visits, in already the backdrop of many women not obtaining the postpartum care that they need, even prior to COVID times. There are a lot of reasons that telehealth is suboptimal for our patient care. For some of our patients, it's easy for them to access their doctors using their phones, their internet. But many of our marginalized populations are just becoming increasingly marginalized with this move to telehealth, with lack of access to reliable phones, lack of access to internet. Maybe they don't want their doctor's office to be coming into their homes. And so there is certainly a big gap here that we need to be concerned about. Sorry, next slide, please. So I have a couple questions for you to think about here. Thinking about your own practice, I'm wondering how you would characterize ambulatory postpartum care right now in COVID times. Is it primarily in person, primarily telehealth? You don't really know because you work on the inpatient side. And then my second question, and you can go ahead and start answering whenever you're ready. My second question is, do you think or do you know if your moms are getting screened for postpartum depression? So maybe, yeah, if they come in person for a postpartum visit, you think they are by telehealth. And again, this isn't just like, how do you feel, but using a validated screening tool. Maybe you hope so. You don't really know. The last question, the last choice at the bottom here, you have to scroll down to see it, is, uh-oh, I think that might have fallen through the cracks. So I look forward to seeing your responses. So it looks like so far about half of participants are not really sure how their moms are getting their postpartum care. And among those that are sure, 33% are getting telehealth care. And then for their postpartum screening, about a quarter in person, about a quarter by telehealth, 23% are hopeful that that's happening. And only 7% are fessing up to thinking that that may have fallen through the cracks. I hope that that's true. So I'm going to talk to you a little bit about the program that, that we have put into place. And I will say that this is absolutely a real world solution using resources that we have, and not an ideal world solution at all. So again, this was really just adapted to what we had. So, our team initially was meeting Monday through Friday, every day, interdisciplinary team from our practice, trying to address both the prenatal and postnatal care of our moms during the COVID crisis. And we realized quickly that the resources that we had available to us are our people. So from the beginning, we have had a bunch of providers working remotely on a day-to-day basis. So these include physicians, physician's assistants, nurses, and also our practice assistants. Next slide, please. So we wanted to really harness the power of our remotely working people. And this is what we've come up with. What you'll see quickly is that there's a lot of redundancy here. And the reason, I'll go through it step by step, but the rationale for the redundancy is that we're not doing a lot of surveillance right now, really for bandwidth issues, to assess just how many of our patients are getting the EPDS, just how many of our patients are even getting postnatal care. So we're trying to give them many contact points with our practice to try to encourage them to connect with us during this very challenging time. So our protocol starts with a postpartum call, which is done during the inpatient stay by a physician from the practice who's working remotely to establish their postpartum care plan. As many academic centers, we do have residents who are seeing our patients postpartum in the hospital, but that care tends to be focused really on their inpatient stay rather than on their longitudinal postnatal health. So we have a doctor call them upstairs and make sure that they have a plan set into place, identifying whether they're high risk, for reasons of, for example, diabetes, hypertension, mood disorder, traumatic birth, poor obstetric outcome. We have a whole checklist that they go through in order to identify whether patients need to have a near postpartum, so within the first couple of weeks, in-person visit or even phone call, and what the rest of their postpartum care should look like. We have a postpartum list that is triggered every day by the deliveries, and we have a practice assistant who's working from home. And what she does every day with the new deliveries is to attach a postpartum letter and a postpartum depression questionnaire to a message encounter in their electronic medical record. And I'm going to show you how to do that on the next slide, so that they will automatically receive an EPDS, and again, this letter from our practice, about a month postpartum. And then any positive result will automatically go back to the provider that ordered it. Our patients then receive an outpatient phone call within the first 2 weeks postpartum by one of our practice nurses, unless they've had an inpatient visit during that, or an in-person visit during that time. And then they finally have a postpartum call with the MD between 6 to 8 weeks postpartum, or with one of our physician's assistants, unless they need for some reason to have an in-person visit. Next slide, please. So this is just showing you I know a lot of practices are using Epic, and this wasn't functionality that I was familiar with, so I'm working under the assumption that not everybody is. So this is a message, this is in my own electronic medical record. So you see it says to Nicole Alexandria Smith, and in the left-hand area, we have a text that we insert, which does basically postpartum counseling of what people can expect, now that they're about a month postpartum. On the top right there where you see circled, the code for Epic is W plus whatever is number of weeks. So we put in W plus 4, so 4 weeks after their delivery, they're going to receive this message in their patient gateway or their patient portal. So again, with text from our practice, and then also with an attached questionnaire. And then if you scroll down, you can choose which questionnaire you want to attach. So here I've attached the EPDS questionnaire. Next slide, please. So a couple thoughts on our protocol at this point. Again, it seems redundant. It seems like a lot of phone calls, and it is. But we are hoping that by having these universal protocols with the redundancy in place, that we will be able to achieve more equitable postpartum care, and trying to use the same protocol for every one of our patients. I would say the strengths of the program are that, well, we're trying really hard. We're doing the best that we can within the restrictions, both of trying to reduce patients in our office as well as with staff bandwidth, which is a real concern for us, as I'm sure it is for all of your practices. In terms of the limitations of the program, well, inevitably, we're still going to miss some mood screening. We're still going to miss some diabetes screening and contraception. And again, it's not an ideal plan. It's just the best we could do within staff bandwidth and the pandemic. Next slide. So a couple of resources, I was really thrilled to see the resources that the Betsy Lehman Center has put together. One thing that we've found has been the most taxing among our providers is this, the emotional burden that the patients carry, and also that we're all carrying as our lives are disrupted, and many of us are struggling to keep our families together and our work together at the same time. So the patients tend to be fairly appreciative as well of some of these resources. We have, of course, the McPap for Moms program has a lot of information on their website, and this is another site a lot of people are familiar with, the Postpartum Support International, PSI. They have some particular COVID information. Next slide. And one to add to the Betsy Lehman resources, but also for our own practices, is this free guide to living with worry and anxiety amidst global uncertainty. This is open access. It's been translated into about 10 different languages. It's not pregnancy specific, so it's useful for staff as well as for families. Next slide, please. We have a plan in place for evaluating our program, both looking at women with 6-week postpartum visits, also for their EPDS and contraception. We do have ongoing challenges. We're not doing the universal SUD and domestic violence screening that we were doing previously. And it's really hard to identify the invisible denominator of women who just aren't being reached. Next slide, please. Our team works really, really hard, and I want to thank all of them, as well as all of our other nurses and practice assistants that have been making all these calls and reaching out to patients. Next slide, and I'm happy to take any questions.
Great. So Nicole, thank you so much. That was really helpful. I like the graphic, being able to see how to send the messages and how that's going to happen. I'm just going to ask one question. We're going to save the rest for the end. But Sarah Shields asked, how do you handle non-English speaking patients regarding portal use? Does your Epic translate any of these materials?
No, it doesn't. We're using the phone translators quite a bit that we call the hospital interpreter, and then they reach out to the patients.
Great. All right, well, let's move on to thank you, Nicole. We're going to move on to our next presentation. This is going to be by Katherine Callaghan from UMass Memorial Medical Healthcare. And she is going to speak to us about taking care of patients with substance use disorder in the time of COVID, in particular, home initiation of Suboxone starts. Thank you.
Hey, everybody. Thanks for being here. I think this is an interesting topic. And just like there are risks with changing the format of your care when it comes to screening for mood disorders, there's risks to changing your format of care with substance use disorder as well. But there's also potential benefits. I feel like my theme throughout COVID-19 is it's not all bad. Next slide. With any initiation, and I use the word initiation, but if you're from a addiction medicine background, what I'm talking about are inductions. That just means something different in the OB world. But in starting medication-assisted treatment, the goal is always to balance a safe start with patient goals and patient abilities. Next slide. A quick poll for everyone. Does your organization offer home inductions or home initiations, unobserved initiations for buprenorphine? We'll give everybody a chance to respond. I think a lot of people know that the traditional way to start buprenorphine is office-based, observed inductions. And it looks like most people either aren't sure of their institution's policies on this or don't currently offer home inductions or just starting to. And this is typical. This would be the typical answer. The traditional way of starting buprenorphine, the way I was trained to start buprenorphine, is actually a 2-visit process. One for consent and counseling, and a second visit in order to actually start the medication. Next slide, please. This is a case study which actually happened before COVID, but I think brings up some interesting points about the safety of home versus office-based inductions. This is Jane D. She's 32. She's a G3P1. She has 11 weeks and 3 days. She has a pregnancy that's complicated only by opioid use disorder. She's using Percocets. She reports that she hasn't used since her counseling visit with us 2 days prior. We do a COW score on her, and she appears to be scoring high enough to start her office-based induction with medication-assisted treatment. And we have her take 4 milligrams of Suboxone by film, and we watch her dissolve it under her tongue, and 20 minutes later, she goes into a precipitated withdrawal. She's taken to the ER and given clonidine and Suboxone. Come to find out, without even thinking about it that morning, as per her habit, she got up and took a Percocet. She'd been trying to kind of clue us into that during the induction. We weren't picking up on the hints. She had been counseled about precipitated withdrawal, but kind of thought it wouldn't happen to her. And yet it did. Part of the problem was she didn't feel like she could get to the office safely without taking Percocet. And so we decided to do a home unobserved induction. We gave her a worksheet to help her do that on her own. And we gave her a prescription. Well, actually, she already had the prescription for Suboxone films. Next slide. So the traditional way of starting Suboxone is you meet with the patient, you counsel them to all their different options, you talk to them about the risk of precipitated withdrawal, you sort of come up with a plan for them to go into withdrawal at a point of time in the future that works for your next appointment. That's typically done around doctors and office staff schedule, not patient schedule. You get informed consent, you get prior authorization for insurance. And the benefit to this is really, the person can start their treatment in a medical setting. If there is precipitated withdrawal, they can be brought quickly to the emergency room and treated. It does require the patient to tailor their use in order to fit a doctor's format. And the very nature of addiction is that people can't start and stop use of substances when they want to. And so this can be difficult. It can cause a delay to treatment. Somebody's very, very motivated to start treatment right away, and yet we ask them to hold off for a certain period of time in order, again, to fit our schedules. And it can create a barrier to care for people who don't have easy access to transportation or who don't have all the control they would like over their own work schedule. Unobserved home-based inductions can help remove some of these barriers to recovery. For some patients, it might be more comfortable starting the medication at home. It lets the patient start therapy on their own schedule, and it may actually avoid precipitated withdrawal if the patient can do this on their own timing as opposed to a clinic-driven timing. Now, it does make people nervous for possible patient attrition and diversion. This has always been my concern in starting home-based inductions. You're writing a prescription to a patient, and they could disappear with that prescription. It could lead to diversion. It does remove a relationship building opportunity. Traditionally, I observe patients for an hour in the office after their first dose. That gives me an hour to talk to a patient, or it gives my peer support an hour to talk to a patient. It also requires that the patient have a safe home and a comfortable home to start their own induction, which is certainly not all of our patients. Next slide. Some of the challenges in starting a home-based induction protocol is provider comfort and going against some of the tenets of our training, and that it's supposed to be a two-step process, that the patient should be directly observed. One of the challenges I had before COVID was a lack of a telehealth infrastructure. It's not something that was done at UMass, at least not in my division, regularly at all. And now it's quickly becoming a preferred method for certain visits. I also still struggle with the idea of informed consent. I worry that patients will choose home-based inductions because it means they can start right now. Whereas if all the risks and all the benefits are considered, it might be that methadone may take a couple more days to coordinate, or even just another day to coordinate, but might actually be the right choice for the patient. So there's still challenges to be worked out. Some of the systemic changes that have happened to really facilitate home-based starts for buprenorphine have happened because of COVID. SAMHSA did release a statement that was really strongly worded for a government agency, strongly recommending use of telehealth for patients with substance use disorder. The DEA issued clarification around the use of telehealth. They actually just reissued a statement from 2018 that interpreted a telehealth exemption to the Ryan Act. The Ryan Act insists that prescribing be done only after an in-person exam. But if you actually look at the language, and the DEA clarified this, telehealth is acceptable when the provider is licensed in the state that the patient will ultimately be seen in. Basically, that most of the conditions for telehealth under COVID make this acceptable. Mass Health has also expanded coverage for telehealth, making this more desirable to institutions as a whole. And all of this is leading to the rise of telemedicine for medication-assisted treatment. Next slide. So for supports for unobserved home dosing, if your institution is going to be doing this, if you're going to be doing this, using a telephone visit to check in with the patient, if they have an idea of when they might be starting, around the time they might be starting, allowing the patient to call in and let you know when they've started, and checking up with them shortly after. Peer supports are wonderful in many settings, including this. And then the use of as-needed medications. Some of the medications that I frequently prescribe when somebody is going to be starting medication-assisted treatment includes clonidine, and for the obstetricians, this can lower the patient's blood pressure. So I use it really with care in that sort of mid-pregnancy state, 17, 18 weeks when her blood pressure may still be going down. I'm really careful about starting clonidine so that I don't bottom her out. Zofran, hydroxyzine, Tylenol. If somebody calls, you're on call, a patient's doing a home-based induction of buprenorphine, you're not super familiar with that. One of the things that you can do if somebody's going into a precipitated withdrawal is actually give them more buprenorphine. It's a high affinity, receptors have high affinity for buprenorphine. If you give enough of it, it's going to push everything else off the receptors. A patient will eventually feel better. There's been some newer data on redosing buprenorphine can actually help a precipitated withdrawal. So I typically start with 4 milligrams, and if somebody feels worse, I give them another 4 milligrams. That's actually what the emergency room did with the patient who's part of the case study, and she did feel better. Clonidine is also helpful. When it comes to counseling a patient, I often use the phrase perfect is the enemy of good. The goal here is not perfection. The patient will not feel perfect right away. It's going to take a while for her to really feel good. The idea is to get her to functioning. Can she function? Is she controlling her withdrawal enough to be able to take care of herself? Not perfection. Also, often thought of as the goal of medication-assisted treatments, and that's not always the goal. Decreased risky behavior, decreased use, sometimes that's actually a patient's goal. And so starting a home-based induction and having somebody come back a week later and say, I still used oxycodone here and there, that doesn't mean that you've failed. That is not a failure. It often takes patients weeks to become abstinent when abstinence is their goal. So just keep in mind, perfect is the enemy of good. Next slide. For resources, coming up with a protocol, if you're going to be doing this regularly, is a good idea. I would consider entry limitations, but give yourself and your partners the freedom to be flexible and adapt to patient needs. The example I give is I try not to do these with a gestational age with a gestational age greater than 24 weeks. However, if the patient is unable to do anything else, I will still do a home-based induction with proper counseling and lots of documentation. A home worksheet can be really helpful for the patients. I found this one through the American Society for Addiction Medicine. It's a patient's guide to starting buprenorphine. It's 4 pages long. You can use it with permission from the collaborative that came up with it. There's a link here. I'm sure everybody will get these slides afterwards and can use this link to use this document to give to patients. It talks about how to evaluate their symptoms, how much medicine to take when, warning signs, different supports. It's really, I think, well done. And I would encourage frequent follow-ups on the phone and encourage peer support for anyone who's doing a home induction. Next slide. So in conclusion, thanks, Penguin and MPQC. As always, my lovely Green Clinic care coordinator, who was formerly our peer support, Kristen Piscator. Thanks, guys.
All right, great. Thank you so much, Dr. Callaghan. It's so interesting, and I love the idea that that you're using this pandemic and this emergency to help bring forward and bring new practices into the fore, and that's what a lot of people are thinking. I still remember the days when we would do insulin starts for diabetics in hospital, and it was very odd to think that they would be done at home. So it makes a lot of sense what you're doing, and it's good to have someone who's expert in the field doing this. How many of these home initiations have you done in your practice so far? And after that, we're going to move on to the next speaker.
So I'd estimate that prior to COVID, I had probably done 4 or 5 home inductions. And since COVID, I counted last night, I've done 5. So really it has accelerated my comfort level with this. And I really do think it's going to be a great service even after the time of COVID.
Yeah, it's great to hear that's going to continue. Thanks so much. Our next speaker is from Boston Medical Center. It's Dr. Katherine White, Kate White, and she's going to talk about postpartum contraception and adjustments to think about in the time of COVID-19. Thank you, Dr. White.
Thanks so much, Dr. Iverson. I'm really happy to be here today. Thanks so much to Penguin and MPQC for letting us highlight some of the work we're doing with our statewide program. And we're hoping that we've got some resources that will be really useful for everyone on the call today. Next slide. We know that the COVID-19 pandemic has been affecting contraception provision across the board. We know this on the ambulatory setting, where anything other than essential visits are being converted to telemedicine. And we know it's also happening in the hospitals, that patients are having more difficulty than ever accessing postpartum contraception, partially because tubal ligations are being considered elective surgery and often being postponed or just not permitted to take place. Patients are going home from the hospital earlier than ever. Some cases, I think patients are fleeing the hospital with their baby to get home to where they perceive it safer. And we know with postpartum visits being converted to telemedicine, it is making an impact on methods that actually require something from us with regards to device placement or injections being given. And I think that this delay or access problem with contraception is going to worsen the challenge of rapid repeat pregnancy, which tends to be a sort of a subset of all unintended pregnancy and reflects pregnancies conceived within 12 to 18 months of giving birth. We don't have good data on rapid repeat pregnancy from Massachusetts, but we do know what our unintended pregnancy rate is and how high it is, that it's 40 per 1,000 women of childbearing age, and that almost half of all of our pregnancies in Massachusetts are unintended. We know that vulnerable populations are at higher risk for all of this, for unintended pregnancy, for not being able to access the contraception they want, for not being able to attend prenatal visits as much. And we know that telehealth not only is impacting our ability to give birth control methods to patients, but also probably affecting our ability to counsel them. I know a lot of providers aren't really used to doing this over the phone or by video, and we suspect anecdotally that it's sort of throwing off people's patterns and rhythms about the kinds of things they discuss and how long they discuss it. Next slide. So it's really important more than ever that patients go home from the hospital after a delivery with a contraceptive plan. This could be anything from condoms and Plan B up to highly effective methods like long-acting reversible contraception. So I'm curious to know, and the poll is open now, do you offer now IUDs and implants for any of your postpartum patients while they're in the hospital? Is it yes for both devices for all patients, what I call postpartum LARC nirvana? Is it one device that's available for all patients? Is it both devices but only for mass health patients? Is it you've managed to squeeze out one device for mass health patients? Or do you have to reserve them for patients with high medical need? Or is there some kind of other process that you're doing, or is this still unavailable? I'm just chatting with you while you vote before Barbara closes the poll. We know that starting postpartum LARC is not easy, but we also suspect that there might be a bit more incentive to do so in the time of COVID when you know that you don't have that postpartum visit to rely on. So about half of you are not able to offer this at all to some patients. Hey, yay to the 32% of you who are in postpartum LARC nirvana. That is great. But it seems that a lot of other people on the call may be able to get something out of the things that we're talking about. I'll take the next slide. So just a really quick overview of what our program is. PIC stands for Partners in Contraceptive Choice and Knowledge. And this is a Health and Human Services funded 5-year program to try to improve contraceptive access and quality at the birth hospitals in Massachusetts. So if you have not heard from us directly yet, you will in the next year or two. We are directly engaging with hospitals. We're also doing statewide activities in the series of webinars that had started in January and an annual meeting in September that will either be at Mass Medical Society if the world is different, or like this on Zoom if the world is the same. We also have a series of resources that we've either created or curated available on our website, pic.org. And everything I talk about today that we have created is available now there on the website for free download. We have a whole section on COVID-related programming. This started off with a webinar on April 2nd, Contraception in the Time of COVID-19. We were really grateful to get 140 people who watched it live, and an additional 100 people have accessed the webinar, which is archived on our site. We've created a dozen resources for providers in how to improve or address their contraceptive services during the pandemic, including a sheet on telemedicine best practices and how patients can access birth control without a visit. We also have an upcoming webinar in early June about things to think about as you're reopening services. Next slide. So in thinking in particular about, so next slide please, around postpartum LARC. And if we have a frozen screen, I can go to share my screen. Ah, there we go. Thanks so much. So when it comes to our resources around immediate postpartum LARC, what we have been doing with hospitals and can do for your hospitals is we can do group presentations in terms of grand rounds or other kinds of gatherings of lots of providers. We can also do targeted nursing education for labor and delivery and postpartum nurses. This also can be about more than just postpartum LARC. It can be about postpartum contraception in general, specifically how it is affected by lactation and how patients who need birth control and want to breastfeed can balance those two. We also work with champions on site because we know that change is hard and it's probably best when it's initiated from within. So what we can offer is technical assistance for folks on site to help get protocols adopted, to help them align with stakeholders, work with their pharmacy and billing and things like this, as well as offering resources. We have a lot of printed resources like the one pictured here, which is a one-pager on how you insert an IUD immediately post-vaginal delivery. Next slide. So for postpartum LARC implementation, we have a champion toolkit. Basically, it's an expanded checklist, and it's pictured here. And for those of you who have eyes like I do and can't read that at all, it is available on the website. And so for our program, we are measuring both process and outcomes measures, which we would encourage you to think about if you are starting this on your own. In terms of process measures, how many trainings you are able to conduct, what percentage of staff are getting trained, and what does your credentialing look like? For outcomes measures, can you get a protocol adopted, which we know takes a really long time to go through multiple committees at some hospitals, once devices are available, and then how many are placed. We're also getting qualitative data from our interviews with the stakeholders on site. We would encourage you to consider the same about what were the things that made this whole process easier or harder. Next slide. And just a sort of overview of some best practices of what we have learned. This whole process takes longer than expected. We anticipated this would take months at institutions, and it looks like it can take up to a year. We're hoping that there's a bit of a fire due to the COVID pandemic, and that might help move things along, but patience is definitely called for when starting a program like this. Don't forget to align with stakeholders early. You don't know where obstacles might come up. Is it going to be pharmacy is unclear about procuring devices? Is billing confused about how to actually get paid for them? And so we want to sort of get everybody in the room early in the process. You also want to make sure you're looking at balancing measures to sort of guard against reproductive coercion, because sometimes when a program like this starts, there's an impulse for everyone to want to give every patient one of these LARC devices, which not all patients want. The counseling around these devices starts in prenatal care, ideally in the 3rd trimester. You also want to think about maybe using a metric around just counseling, about who gets counseled for postpartum contraception, not just about LARC itself. And then how many patients go home with a method. We really feel strongly that patients going home with a plan, no matter what that plan is the way to guard against rapid repeat pregnancies that are unintended. And it might not be a LARC method. Think about sustainability from the beginning. You can advance back to that other slide. So sustainability from the beginning, like in terms of training new staff and how you sort of make these changes real. I'll take the next slide. I want to give a huge thank to the entire team for PIC, including Dr. Iverson and Dr. Meadows on this call. And again, all of our resources are available on our website, as well as a contact us form if you'd like to talk about what kind of programming our team could bring to your hospital. Thanks, I'd love to take questions.
Great, well, I'll start with the first one. Thank you so much, Kate, for that presentation. It's super helpful. And I encourage people to reach out to Kate White and to check out the PIC website, because there's a lot of really good information there that's easily downloadable and hopefully something that you would want to implement in your own space. My question is, have you been getting particular questions from patients regarding COVID and contraception that you've been answering? And are there any changes in your counseling in the time of COVID?
The biggest change to contraceptive counseling during this time has actually been the questions come from providers, not from patients. Patients want to make sure that if they are COVID positive, can they get an IUD or an implant placed? And that is fine. Our feeling is that if a person's not showing signs of florid sepsis, there should be no reason why you can't place one of these devices. But the other issue is around the hypercoagulability that we're seeing with COVID patients, that this has not been written up yet. It's not well understood, but it seems that COVID positive patients who are sick enough to be hospitalized have a VTE risk that is elevated, and they're going on anticoagulation. So in the face of that, again, the lack of evidence, this is Twitter medicine that is sort of circulating anecdotes. Any patient who is sick enough to be hospitalized for COVID probably should be taken off of any estrogen-containing contraception because of the elevated VTE risk with those methods. But for these asymptomatic patients in the community, people with very mild symptoms, I would say don't take them off their birth control, because the risk of an unintended pregnancy is probably higher than their risk of VTE.
Great, thanks. I'll get out of the way. I'm going to let Dr. Meadows take over with Q&A from now on.
Thank you to all of our speakers. That was terrific. We have a few questions in the chat, but less than usual. And so actually, I think that allows us the opportunity to allow Ellen Cullen to ask her question directly. So Ellen, are you unmuted?
I believe I am. Can people hear me?
Great, thank you. Yes, Ellen has a question for Dr. Smith.
Great, yes. So considering and thinking about these unprecedented times that we're in, I'm thinking about substance use disordered women who are trying to, kind of parent their newborn. and they may be in residential care, or they may be trying to connect and keep going with their outpatient care. What are hospitals doing, or what can programs in the substance use community do to support thinking about postpartum depression and how we can support these women moving forward?
I think that's a great question. If I understood correctly, it was what can residential programs do to help to support postpartum women? I think that falling back on the validated tools is probably a great place to start. And there are lots of them out there. The EPDS is the one that is probably the most commonly used. But it is always surprising to me, you know, when you have a conversation with a patient and she seems a little off, but you ask her how she's going and she says it's fine. And then you use a validated tool and she scores like 15, you know, which is a high risk of depression. It really gives you some different insights into the patient than you received with what you thought was a pretty personal conversation. So I guess that's probably the easiest place to start, and the EPDS questionnaires are available anywhere online.
Great, thank you.
Terrific, thank you. We also have a question from Sarah. Is Sarah unmuted? Sarah Thibodeau for a question for Dr. White.
He's not. She said she's comfortable with you asking the question for her.
Oh, sure. Thank you. There were two questions, Dr. White, from Sarah. One that you'd answered in the chat, but I'll just let you comment on it. Are there difficulties getting insurance to pay for LARC if it's inserted immediately postpartum?
So Mass Health now, for the last 2 years, does allow sort of unbundling of immediate postpartum LARC placement from the global OB fee. So you should be able to get reimbursed for both the device and the insertion separately from what the hospital bills for the pregnancy. Commercial carriers are a little bit trickier. Most of them do carry it, but I would recommend that patients with commercial insurance check with their insurance company prior to coming into the hospital for delivery if that's what their plan is.
Great. Her second question was, there is a perception that LARC, or IUD specifically, do not work if it's placed immediately postpartum. What would you respond to that?
I'm happy to report that the IUDs are as effective when they're placed in the hospital, even if it's immediate post-placental. There is an elevation in the expulsion risk, which is why we talk about, when we do some training, we talk about using an ultrasound and making sure you get the IUD all the way to the fundus, which reduces the expulsion risk. But if the device is in place, it works just as well, even when it's placed in the hospital.
Terrific. There's another question for you, Dr. White, about patients who are sick enough with COVID-19, who've been admitted pre-COVID, now being managed at home. Are you advising they discontinue estrogen-containing methods for them, given this risk of hypercoagulability?
This is so tricky because with pregnancy, we really know that the biggest risk of a clot is in the 6 weeks postpartum, right? And we have no idea how long the hypercoagulable state lasts with COVID. So for a patient who is well enough to go home, I think shared decision-making is probably the best way to go. That if they can convert to a progestin-only pill for the next few weeks or a month while they're recovering from COVID, which we know the recovery can last a while, that's probably going to be the safest thing for them. But if they really like their method, really want to stay on it, and are feeling well enough to be sexually active, then their risk of pregnancy may be higher than their risk of a VTE. So I think a really good conversation with the patient is good, but I wouldn't withhold the estrogen from the patients who are going home.
Thank you, Dr. White. Sarah Shields has a question, and everyone on the call now has their own ability to unmute themselves. Sarah, if you're able to unmute, you can ask your question directly, or I can say it for you as well.
Hi, can you hear me?
We can. Go ahead and ask your question.
I was just wondering, this is for Nicole and anyone else who, I was just thinking about the validity of the EPDS with multicultural populations where maybe they're not as comfortable talking about these symptoms, or their cultures define them differently. Maybe they are reluctant to talk to the white doctors about this, or others who don't speak their language, or worried that if I say something, DCF's going to get involved. And how do we address those issues when we're talking about the risks in our marginalized populations in particular? Thanks.
I think that there's some data, and hi, Sarah. I think there's some data on some different populations with using the EPDS. The EPDS has been validated in some languages and has been translated into many. On the MCPAP for Moms website, you can find the EPDS in a variety of different languages. In our practice, we have it printed out in probably our 4 most common languages so that it can be directly administered. And on the websites, you can translate it into additional languages as well. For those that are interested, you can also get the NIDA screen translated into many different languages as well. And I have a link for that if anybody wanted that, so that you could actually administer a paper version of it. But I think, Sarah, ultimately, I'm not sure we can answer that question. We've certainly had positives in lots of languages. And I think that what is universal is people do appreciate being asked. And then at some point, that's all we can do. I hope that somebody else has some great insights on that as well. I'm certainly not, the expert.
I've found that sometimes it's helpful to have somebody who's of the community, so a community health worker particularly, who can help sort of bridge some of that translation that is more than just the language translation, but the cultural translation. And some women are more willing to talk to those people than they are to me about the issues. So I think it just brings the issue of, even if we have the right written language for somebody, it might not always bring out the conversation in the same way that we anticipate. So I just thought that was worth thinking about if we're talking about how to talk about all of this in the most vulnerable populations.
Thank you. That's a really important part of our discussion. As folks have the ability to unmute themselves, are there any other questions for our 3 speakers? There is a question that I want to bring up as well from Dr. Katz, but I'll give a moment to see if there's any questions related to contraception, substance use disorder therapy, and depression screening in the age of COVID-19. And then we'll actually have an interesting comment from Dr. Katz that we'll bring up for open discussion. Okay, Donnie, are you able to unmute yourself and pose your question? We have at least, I can tell, 5 or more hospitals represented on this call among participants. And if folks have, opportunity to answer, it'd be great. If you can unmute yourself and raise your question related to screening for support persons, I'd love to hear this conversation as well.
Yeah, so I think a number of weeks ago, partners made sort of the decision that it's impractical and in a way to really try to test the support person of a COVID positive patient. There was an email that went out yesterday from the DPH that's circulating that basically recommended testing anybody who's exposed to a COVID-19 case and then quarantine themselves. Our pediatricians have been working on a protocol to test the support person. And I'm just curious to know what other hospitals are doing. It's sort of, to me, I unfortunately view this as a lose-lose proposition for our patients by losing the support person potentially if they're already COVID-19 positive. So I'm just curious to know what other hospitals what their thoughts are or what they're implementing.
Great, Ron, do you want to talk about what VMT may be doing? And
Sure.
Dr. Zeros on the line as well, maybe for BI.
We're not actually able right now to be testing partners. If they have symptoms, they're asked to go go downstairs and get tested, and quarantine is appropriate. Dr. Callaghan.
So I'm running the CARES clinic here at UMass for COVID positive women who need obstetrical and gynecologic care. And we've had this come up a number of times where we were expecting delivery and the patient's support person had also tested positive. And the current UMass guidance is that we're allowing COVID positive support people if it has been more than a week since their symptoms appeared, or if they were an asymptomatic carrier, more than a week since their positive test, that they've been afebrile for 3 days, and that they feel like they're improving. And so we do have COVID positive support patients and asymptomatic carriers here on Labor and Delivery.
Great. That's very helpful. Thank you.
Other hospital systems that may want to report what they're doing in that area? Elizabeth Kester says at BIDMC, we have not made the move to test support people in L&D. There has been discussion related to supporting the NICU, ruling out support person, but we haven't done it yet.
I just want to say that at Newton Wellesley, the push has been from the pediatricians all along, and this has been going on for 3 weeks now. We do have the capability to test, but logistically, I've been not happy with the idea of removing the support person. You can understand.
Dr. Katz, Sarah Thibodeau at Lowell General also says we cannot test support persons at Lowell General. We do not have resources to do so. From South Shore, the response is we're testing partners of our scheduled C-section and scheduled inductions. Oh, that's nice to know. I hadn't heard that yet. And Dr. Callaghan also added, yes, at UMass is routinely screening support people, but not testing.
Yeah, we also routinely screen them, and we also take their temperature on admission to Labor and Delivery, the support people, but we haven't been testing.
Fantastic. At Lawrence General is also testing support persons for booked procedures. And at North Shore Medical Center, we screen, but we do not test, from Dr. Preston. And Alex at Tufts Medical Center says no testing for partners at Tufts, but routine screening and clinical clearance of prior positives per the CDC. Terrific. We appreciate all the responses. And knowing we have 2 minutes to the top of the hour, or at the bottom of the hour, I should say, I will turn this back over to Ron Iverson and Barbara Fain.
Okay, I'll say my quick goodbye. Thank you very much for everybody who spoke today. Thank you for chatting, coming off mute and asking your questions. And Barbara.
Yes, and I will echo Ron's thanks. It's great to see all of you. We will keep the chat box open just for a couple of minutes. If you're not already on our distribution list and do want to receive notices of these meetings, all you have to do is type your email address into the chat box and we've got you covered. The other thing I wanted to mention is that we've been doing these weekly for the past 6 weeks. We thought we would just try switching the cadence to every other week. So next week, if you're looking for us, same time, same place, you will not find us here, but you will 2 weeks from now. So, so again, thanks everyone. This has been a great conversation as usual, and good luck, take care, and we'll see you in a couple of weeks.